particularly in Burkina, looking at the consequences of the payments, including asset sales, which I mentioned earlier, also the amount that is spent in absolute terms, which is particularly high for the poorest group, and the high frequency of borrowing, use of sales and other assets. 8% of women with normal deliveries right across the board reported having to borrow to meet the cost of care. The third strand of the different studies which were carried out as part of these complex evaluations produced findings on gender and other kinds of variety of cultural barriers. For example, in Burkina Faso, willingness to pay for maternal health care was carried out. And one of the expectations was that women would be prepared to spend more on maternal health care, allowing for education and income levels. And in fact, the reverse was found to be the case. Women were prepared to spend less, and this is assumed to be related to issue of lower capacities and lower ability to control household income. There's also been some work done on a gender status index linked in, again using the sisterhood method linked in with maternal mortality, and that's shown a strong correlation, although that's still under development. A number of the countries found evidence of ways in which traditional practices benefited and promoted informal care over facility-based care. And also gender barriers, for example, in Senegal, the only skilled provider within the health centres tends to be a nurse who's male. And so particularly amongst certain ethnic groups, there's an unwillingness to allow women to go in for care because they will be seen by a man, which is not culturally acceptable. And of course, the dominance of the mother-in-law. There's always a mother-in-law somewhere, isn't there? But that came out very strongly from the Senegal findings, that even if the woman is paying for care, she's not the one who decides where she goes for her delivery. It's her mother-in-law who decides that. So, education also comes out as a strong theme, and a multivariate analysis was carried out in Burkina, which found only that distance and maternal education were highly significant. And if you look at the caesarean rates by educational quintile, you see that although it's only 0.4% overall in the sample that we looked at, for women with secondary education, it's dramatically higher at 2.4. That's dramatically higher for Burkina. It's still not absolutely very high. So what are the policy implications? Well, on the demand side, looking at these three themes of too far, too costly, too unfamiliar, it provides very strong support for the role of transport and support for direct costs outside the facility for women who are living at a distance from health facilities. And often in many settings, these are very substantial and more substantial than the formal facility costs. And I think Wendy will be talking to that theme. On the cost side, encouraging communities to save for predictable costs, but also addressing the substantial emergency care costs which we've highlighted. And of course, enhancing their role in decision-making and their control over resources and poverty reduction measures, particularly ones which address the female income. Community mobilisation is something which has come out, particularly in Burkina, came out as one of the more cost-effective strands of the skilled care initiative, and of course promotion of female education, both independently valuable but also in particular in relation to demand generation here. On the supply side, the findings in relation to barriers does point to a need to provide targeted investment, particularly in countries like Senegal where distances are very large, and of course also countries like Nepal where the topography is such that getting access to facilities is very difficult and time-consuming and costly for families. And then, of course, also addressing the household costs, particularly, as we said, emergency care, but also for the poor, all types of delivery care can be unaffordable. And improving the predictability of costs. And there are a number of ways, a number of different schemes to address these issues. We've talked a bit about exemptions and social insurance, also improvements in targeting of those. And and reducing some of the informal barriers that we've discussed. And of course, increasing the package of care that's on offer in the public facilities can directly reduce costs. I know when we were doing the evaluation in Senegal, there was a lot of concern that although they were reducing official fees, because drugs weren't available, families were having to go outside and buy from the pharmacies. So actually the effect could have been perverse of increasing the overall cost, because these were private pharmacies where the costs were much higher. And then finally, the issue of relations with providers, which hinges around particularly attitudes, as Julia mentioned, but also the convenience of services, the siting of services, the hours they're open, and the acceptability in terms of who are the providers. Thank you very much.
Okay, thank you very much, Sophie, Julia and Cindy as well. Into the final straight, as it were, in more ways than one, to talk about what this actually means for going forward in terms of enhanced strategies. I mean, when we set out with Impact, we hope we would find evidence that could strengthen strategies in country, and that's the step that we're at. It might sound very negative. Indeed, you could argue that indeed some of the findings are shocking. Not surprising from some people who worked in this field for a long while, but quite shocking in other ways. But the issue is to try and use those now to inform progress and to find out how things could be done better. And it's sort of somewhat unusual for researchers to enter into this dangerous territory, but we do so with support of others. But I think it's so important that researchers come part way and try and close the loop of their work and really make the difference that they set out to do. So I apologise for those slides I've used this afternoon in the tools part, but I'll perhaps try and say them slightly differently. But I think it's very important that what we've tried to do, I mean, you think about Impact starting and being conceived back in the year 2000, 2001, although evidence-based culture and evidence-based decision-making now seems like sort of old hat, it wasn't at that time. And I think we had to fight hard around the whole issue that evidence had to be used for informing strategies. And I think it's so important that when the pressure on resources, as in the countries we've worked on, is so intense, it's even more important that you try to shift decision-making away from being opinion-based, obviously along into the evidence-based loop, as it were. So where we are now is that we set out on a journey which actually started with almost a year of working out with the countries in which we worked what the priorities were for the decision makers. What was their view about what did they really want to know about the strategies in place in their country? And it was a very painful process, and a year on I really thought we were doing it wrong. But now I realise it was the right thing, but it takes time to really understand those perspectives. So we started off with this process of assessing priorities. We have, as people have imagined, created this onion of evidence which we've gathered, the measurement fest, everything that moved, we measured, we synthesised, we've tried to repackage it. And now we're here in this step of communication and translation. And the loop has to be closed by trying to position this evidence in a way that informs the design, implementation and continuous evaluation. Even if you propose an enhancement, it's very important that you also propose continuous evaluation. All you can do is offer recommendations for progress, but you also have to provide those tools and expertise to make sure it's evaluated. So in doing this part here, this sort of the translational step and making suggestions for enhancements, there are many challenges along the way. I mean, one of which I've mentioned earlier today was this whole issue of we recognise that evidence might be very central to us as researchers, as academics, but clearly it's not the only thing that people take into account, and we recognise that. However, it therefore puts even more emphasis on getting your messages right, getting them out in a way that can make a difference for that little window of the circle that they take notice of, the decision makers take notice with. But of course you also are quite unpopular, and although we've been very well received, we've just, for example, returned from Burkina Faso where we had an audience with the Minister of State, and he was very receptive to the evidence, and there is follow-on activities. But it's not always like that, and it's not been like that historically either. There's nothing a politician likes so little as to be well informed. It makes decision-making so difficult, complex and difficult. This is a very old quote. I mean, so sometimes I think there's nothing in this world that's new. But yes, you have to recognise that you're also not always welcomed, and sometimes when you're finding the problems and you're not quite yet there with the solutions, it's not. There's other sets of problems, which is this one. We are from very different worlds. We are over here with our bikini top. We are the Venus de Milos, the researchers, in a very different world, and Stuart over here is here. And I mean that partly in jest, but it is so true. Our language, the things that we present, the way that we prioritise certain things, the way we want to hear it, how long we want to hear it, it is so different. But I think I've used this slide for a while, actually, but I actually now need to change it, and I need to bring in all sorts of other planets, I suspect, because it's no longer just these two communities. When people talk about, research evidence into policy and practice, it sounds like, it's the researchers and it's the policymakers, and that's just not the case anymore. It's a very different world, and there's a lot more different audiences that have to be taken on board. So you've got to have your Martians and your Plutonians, and you have to have many, many others that are here. And I think in the next slide, when I talk about translation, I just want to be sure that people realise I'm talking about this step, the evidence filtering and amplification. And we've given a sort of a demonstration of that. I mean, we're talking about very high-level findings. Underneath it are all the layers, the units of evidence. But of course, going to the Minister of State in Burkina Faso, it has to be simplified and amplified. Not that he can't absorb all that other detail, it's just he doesn't have the time, and he doesn't have the inclination either. So this is a crucial step. Oops. Go back. And it is a step that typically researchers don't always take part in. We tend to be seen over here. We might help with some of the priority setting, but we'll certainly do an awful lot of this. But I think it's this issue of us actually going along the pathway a bit further. We can't necessarily work out all the best ways to communicate, but I think it's a meeting of minds, and I think it's very important that it's recognised that this demand for evidence now is much, much bigger. In safe motherhood now, when we talk about holding governments to account, when we talk about the power of evidence, that power does not just lie within the health sector. It's very important the health sector is communicated to, but there are so many other audiences, in particular the group down here, advocates, civil society, NGOs, parliamentarians, for which you need different types of skills and different types of messages. So what we've been trying to do in our evidence filtering and amplification is to try and cut to the chase, and my colleagues here have tried to do this. I can assure you behind each of those tables, complex and detailed though some of them were, there is another layer of complexity. But you have to rise above that and come back with some take-home messages. And I don't think we're finally here with these messages. We know we're not. We're listening to what people are saying. We're listening to better ways to present them, and particularly when it comes to our in-country communication. And if there were to be 4 translated messages from Impact, I hope you would agree that we've given you some background to why we've come up with these 4. These should perhaps be no surprise. The first one, the burden of mortality, borne disproportionately by the poorest or most disadvantaged women. Yes, to an extent, with the familial technique that we developed back in 2004 and then we analysed the DHS, there was insights to that. But you actually have to do that individual, detailed capture to show that relationship and that burden to convince decision makers on the ground. That's really an important problem. The second thing, the financial barriers. I am certainly not an economist, and I would never have perhaps predicted back in 2002 when we started that it was going to be this that was the big bottleneck. Financial barriers to emergency care and skilled care, and major reasons for this burden and inequity. Crucially, lots of strategies have good intent. They want to reach the poor. But in fact, if you use your equity lens, if you go below the layers, you find that actually they're making things sometimes worse, and they're certainly not achieving what they'd want them to. It's the sort of, I don't think Davis and Watkins in the audience, but of course, he's got this wonderful comment about better performance is needed and possible for reaching the poor. And this is absolutely what's needed. There are better ways to reach the poor, and that's exactly what's needed. There's a particular set of issues that relate to the maternity care issue that makes it somewhat different, for example, the emergencies. But it is so important that it's recognised that these strategies don't always achieve, in particular, the strategies that we've looked at, the Ghana strategy, free at the point of service, but women couldn't get there. So the important thing about where to go forward then is being practical about what might be done, using the evidence that's been generated for impact to start to work with countries, not just the focus countries, but others. We can identify generic issues that can bring relevance to other countries. Is the importance of phased and targeted approaches to reducing financial barriers, also recognising the quality of care issue. There's no point in removing barriers to care that's not worth having. You have to do those things together. So we're now at the point of wanting to really work together back with the countries and in the countries that we've focused on, but obviously with many others as well, about the whole issue about ensuring really looking at financial strategies to try and reach the poor in terms of maternity care. So the first one is sort of an obvious one, but again, these are high-level findings. It's important to get some of this detail back to key points. Fully funding the cost of complicated deliveries. I was at an advocacy meeting last week, and somebody said when they heard some of this that, okay, perhaps it should be presented as no woman should have to pay to live. You know, it's this issue about nobody asks for an obstetric complication, rich or poor. So to a certain extent, emergency obstetric care has to be made available to all women. It has to be made available to all women. There has to be, clearly, there is sufficient evidence to suggest that good quality skilled delivery is an important intervention, and the important thing is to stimulate demand, which sometimes also means recognising those demand-side barriers, for example, transport. Encouraging households and communities to plan for costs. I mean, this is a shared responsibility. It's not about handouts. It's about a shared responsibility to enable women to deliver where their care is going to be best. And the whole issue about targeting, universally available or geographic targeting, and that's, I think, an issue to do with partly funding. Midwives are the main provider. You saw the Indonesian work. It was clear that because of the support that midwives require, their salary comes from the payments women receive. Why would they provide services to the care? Of course, many do and try to, but there's a real issue there about motivating, recognising the salaries needed by providers to reach the poor. And of course, the sort of thing that Sophie mentioned, about the importance of the resources. I believe any day now there's going to be a big ask from the Partnership for Maternal, Newborn and Child Health for another 10 billion to go into per year for maternal, newborn and child health, for health system strengthening. That more resources are needed. Anybody who thinks you can achieve universal access without more resources, financial, which can indeed, of course, pay a difference with the human resources as well. More money is needed, and there's no doubt about that. So now what I'd just like to do, I'd like to end off by saying where we are with trying to locate this evidence back in some of the particular countries, and I'm going to zoom in on Indonesia, in part for many reasons, but in part because we've just come from there, and so this is very, very fresh in our minds, but we are repeating this sort of work in a slightly different format, obviously, in the other countries. And when you're trying to position your evidence, it's quite clear you need to create an enabling environment, and that environment takes quite a long while to create. The sort of dialogue that we've had with countries and the chance, therefore, to be at the table. If you look at Indonesia now, I mean, there is actually a timeliness to the evidence if we can put it in the hands of those that can use it to the greatest effect. There is great presidential concern for MDG 5 and where it is and how seriously off track it is in Indonesia. There's actually an ongoing health sector review in Indonesia as well, where the potential is there for quite wide-ranging changes in the health system. There's also a revision of their health system, their national health system document. So there are key policy documents that are in the process of being reformed, that if we can position our evidence in a realistic way, can make a difference. There's an election next year. We know parliamentarians who would love to have some of the information that talks about the costs of care for their political platforms. Now, some of this has to be used advisedly, but these are other groups who can use evidence powerfully. And then it's very important in Indonesia to recognise that budget holding is at a district level, And you have to work with district-level decision-makers who also have different requirements, some quite complex. What you also need to do in positioning the evidence, and this is very relevant for Indonesia, is to think about other evidence. I mean, we've obviously generated some, but there is another body, there's other wider bodies of evidence. And in fact, I think Gib Clark mentioned at the beginning, what was held here back in last October 2006, was the launch of this Lancet series, which was based on other evidence, some impact evidence as well, this call for a new strategic focus, stressing the importance of women delivering in health facilities with teams of midwives. Now, by health centres, the health centre was the word that we used, this didn't mean an all-singing and dancing facility, it meant places where midwives worked in teams, providing 24-hour coverage. And the evidence that we presented in the Lancet, it wasn't just me, there was many other colleagues involved as well, and as Gib has mentioned, one of the launches was here in the Woodrow Wilson Centre. What we were doing there was showing that moving women, enabling women to choose to deliver in health centres because the quality is good and the access to onward referral if there is a problem. Women have to be enabled, they have to have that choice, but they have to be enabled to follow that choice through. So we could show from the Lancet, in the Lancet series, we talk about that strategy being most effective and most efficient. Now the question then in Indonesia is linking that up with the sort of evidence that we found about financial strategies and trying to package that together, because one of the powerful things about financing strategies are they are a form of implementation they are a form of implementing other strategic shifts. In other words, your financing strategy that recognises the importance of overcoming financial barriers can at the same time achieve things like moving women in to deliver in health facilities. So financing strategies act as a sort of implementation channel, which is very powerful. So now what we're working with with Indonesia is we're tailoring the messages that I showed you 4 earlier. We're tailoring them. So what we see now in Indonesia, the first one, yes, the burden is high, but there are still some issues in those other groups. There are in Indonesia, big problem in the poor, but in the richest women, maternal mortality ratio of 232 per 100,000. This is the richest women in this part of the world. There is a quality issue here. Financial barriers, they clearly in this, it's without doubt, it's a major problem. It's actually leading directly to impoverishment. There is quite clear families are being pushed into debt. And I think it's very important the way that we measured some of that. Sometimes people focus on the immediate catastrophe and they forget that the problem continues. A woman who's had a major surgery will need care afterwards. And it's those costs that sometimes push the household below the poverty line and lead to all sorts of social costs as well. Fragmentation of the family. 3 minutes, I'm looking at some my colleagues here to encourage me to move on. Universal access to quality delivery care has to be driven by explicit goals about the person and the place. In Indonesia, they trained the 54,000 midwives placed in the community. The assumption was it was to be community-based care. It's quite clear that the next step in Indonesia has to be to encourage women to deliver in facilities with teams of midwives and indeed with liaison with the traditional birth attendants to encourage women to go into facilities. And the question of the phased and targeted approaches. So moving on quite quickly, the 4 steps. We're now at the point of working with our partners in country, in the Ministry of Health, in our research partners, to come together and develop a financing strategy that then can be positioned with influence, we hope, in the various reviews that are going on in Indonesia. So we're looking for influencing partners. We can do the work, the business, but we have to have those influencing partners. It's a question of focusing on the most important barriers, addressing the supply environment, ensuring this financial cover for catastrophic maternal care, that's the emergency care, and developing the action plan. And if Julia will permit me with 2 more minutes, I'll just show you the focusing on the most important barrier. This shows you the data. As I said, we focused on 3 countries, but we've also done work collaboratively in Nepal. And what this shows you is the important thing about recognising the most important from the household, societal point of view. And this shows you the costs, the dollars per delivery, and these are talking about normal deliveries. And it shows you, for example, in Nepal, in that particular mountainous part of Nepal, that of the total cost for delivery care, the vast majority was actually outside the facility. It was getting there. Now that's that particular part of the country. Whereas if you went into the Terai, the other part of Nepal, there actually the costs of the family were actually much more to do with the costs at the point of service. And so on. And if you go into the urban area of Indonesia, the real costs are here. But if you looked at the rural part of Indonesia, then transport costs, this is rural Pandeglang, start to become more significant. So you have to look at the barrier from the household's point of view. The next thing to go on is look at the supply side, from the service side, and this very context-specific. Contexts vary, and so do the optimum financing strategies. There is, of course, little point in strengthening that demand if the supply is inadequate, but it's so context-specific, and this is our attempt to very crudely, and I always apologise, this is also very much not to apologise for my colleague, but to apologise for how we have to simplify some of the findings in terms of grouping. What this is showing here is two main axes, the demand side and the supply side, crudely divided into where there are high demand side problems, in other words, because there are poor roads, so the sort of mountainous areas of Nepal, versus a situation where you've basically got low demand side costs and relatively good roads. On the other axis, is the infrastructure broadly adequate or is it weak? And it's possible, this is using sort of macro data, not macro as in DHS, but macroeconomic as it were. It's possible to look and see how countries broadly fall. This is clearly the most problematic environment where you have got a good road situation but very weak infrastructure. And you can see, and I'd be interested for those of you who know about these countries, whether you'd agree that they broadly fall into these categories. In Indonesia, we're very interested to carrying our work in Indonesia because it is such a diverse country, and it does mean that all of those scenarios of high demand side costs, adequate infrastructure, and the other way around, parts of Indonesia lie in all of those boxes. And it's important in thinking about a financing strategy to think about where these supply and demand side costs and barriers fall. Sophie's mentioned this one. This is the Venn diagram that shows this issue. About a third of the households would have been pushed into poverty if they had accessed emergency obstetric care. The action plan, it clearly, again, reinforcing context-specific. And that's a challenge sometimes for this sort of global research initiative. We can't work everywhere, but we have to keep saying about how important it is to get specific about the solutions and the way forward. The affordability, the strategic positions. And just a very, very last slide, the issue about a phase strategy. I think it's so important because if you talk about universal access, for some countries that sounds like it's a million years away. And you have to make it more amenable to a phased, that in a first phase what you might attempt and in the second phase. So in a situation that we know very well with our partners in Banten province in Indonesia, the start-off might be, the possible starting might be providing catastrophic care, skilled birth attendants, removing the fees there for the 40% poorest sub-districts, a small transport incentive. What does that cost? Costs about $0.47 of a dollar or $0.92 per capita, depending is the range for in terms of affordability. And down here, if you are moving to universal coverage, all attended deliveries and catastrophic care for all, 1.22 per capita. Now this is using some of our data and showing what the affordability might be. And to put it in context, maternal health spending in this part of Banten province is 0.3. So it's not such a huge hike to go from what they're spending now to this sort of a strategy, which of course we would encourage them to evaluate. So, and I know Stuart is leaving at the very moment when I will encourage him to stay. And of course, this is what you'd like us to be showing. I know you'd like us to be saying, progress and how it can be achieved. And I think when you look at these historical series, you do find evidence, if you dig around, on how they were effective with their pro-poor, however you want to phrase it, what they did in terms of trying to reach the poor. And I suppose when I hear some of the case studies that Julia presented, and again referring back to the meeting last week, people were saying that we, in this community, we have not been angry, edgy enough or troublesome enough. We haven't. And I'm not naturally that sort of a person, but I'm getting there. Which is why I want Stuart to stay on. I'm getting there. So I think there are some signs of optimism, but you've really got to get that strategic focus right. And I hope that in a few years' time we won't be seeing this sort of hospital sign taken from one of the hospitals in Ghana, where the mortuary is right next to the maternity and the paediatric wards, for very pragmatic reasons. Thank you.
Yes, I have got to go. Thanks very much, Wendy. As always, it's a fascinating presentation. Sometimes, you know, you can get a bit down from the problems, but I think there are real, you know, the evidence base is improving all the time. It's giving us solutions, and I think this is a year to be optimistic. You know, it's the halfway point to 2015 and the MDGs. I think people are starting to recognise that while we've been successful in starting to address MDG 6, the major communicable diseases, MDGs 4, child health, and 5, maternal health, and 1B, nutrition, you know, we've really got to up our game, up our act. The Japanese will be hosting the G8 summit of the world's 8 major industrialised countries, and have indicated that they want to do 2 things. They want to get a result that demonstrates a better balance between MDG 6 and 4 and 5, and a better balance between targeted, focal, vertical interventions, whatever you want to call them, and efforts which strengthen and build systems for the longer term, health systems. Because today's problem are the major communicable diseases. 10 years' time, it's going to be non-communicable diseases, the health impacts of climate change, avian flu, and what somebody described the other day as very non-democratic diseases that will be a threat to all of us. So if we fail to invest in those systems today, other positive indicators, I think, on particularly MDG 5 and 4, really are our own parliamentary processes, and I've heard since I've been in the States, your parliamentary processes or your governance processes. Congress, is that the tribe? They are to discuss, you know, greater action on maternal and child health, I think, tomorrow. I'd love to have gone. I've never seen this process in action. And in our own case in the UK, we've just had an international parliamentary development committee that's looked very hard and deep, and Wendy's been troublemaking in this process at what we're doing in maternal health and giving us steers on what more we should be doing. And I think there is a sort of a desire to do much more and to do much more of the right thing. The Gates Foundation, with their shed loads of money, are starting to develop a revised maternal and child health strategy and a reproductive health strategy, and we hope that they're going to get a bit deeper into, you know, addressing some of the problems. And I would say finally, you know, you have to give credit to Norway. You know, the Norwegians, again, very wise. All that money they made from North Sea oil, they haven't spent any of it. They've invested it all in the long term, and they live off the interest. The UK, you know, the money that we made from oil, we spent it all. Or we spent all the money that they found in Scotland. But the Norwegian, I'm looking at my watch here, because the Norwegian Prime Minister gave international leadership to this. He announced $1 billion over the next few years for MDGs 4 and 5, and behind him he started to generate, you know, a rolling commitment, and I think this really is a year that we will start to move forward, and I think collectively we'll start to shout loud and be angry and be very focused and have clear messages, which I think, if we look back over the last 5 years, is one of the clear lessons that we take from civil society and how effective it's been in cranking up the volume on AIDS. And on that note, I will leave you. And I'm very sorry to miss the questioning, because I think that's really the most interesting part, having heard all this stuff.
Okay, well, thank you very much. We just have a few minutes left for questions, so maybe let's take a few at a time. Okay, let's start here in the front.
Yes. Alfredo Ford from DHS, and I'm always excited about these presentations. And the one thing today that I saw gladly is that we're kind of pinpointing more and more, and that's good, that's great, because, you know, we're advocating for many things. The one thing that it's coming home now is this thing that we've been saying, well, skilled attendance at delivery. And now we seem to be saying, hey, you know, attendance to facility at delivery, given that we know if a professional, skilled person would still be perhaps in a community, may not have all the resources that are needed. So, but the trouble there is, of course, that, okay, now we are asking women to be shifted, to more urban, more connected, more accessible places, which, frankly, there's going to be still, lots of time, before this happens. But that strategy, which I also concur with, having worked in mountainous regions, in the Andes and such, is that yes, the health center type strategy might work, but we all need then to push really hard because, like I say, and in fact, perhaps the dearth of indicators, Cindy is using smartly, the C-section, indicators, but we need, and that's one thing I haven't seen in research, can we have some kind of an experiment that says, hey, some midwives, well-trained, life-saving skills, working at that intermediate level, can they save lives, as we know from hemorrhage and from infection, from uterus evacuation and application of antibiotics. Can we really make a dent there? Because if we can, then instead of going, the pendulum from one extreme community to the other extreme urban hospital, district hospital, then we could say, hey, let's put a lot of effort here in this intermediate level. But that part of the research doesn't seem to have really come to fruition. So anyway, some comments. But thanks very much, really exciting.
And maybe just pass it back to Charlie there.
Quick question, Charlie Teller, a PRB fellow. I think that it's important for this study to make that link between evidence and policy by letting the international community, particularly economists who are influential in the G8 summit, let them know, people like William Easterly and others, who are claiming there shouldn't be an MDG5 because maternal mortality can't be measured well and is measured only in a few countries. Could you comment on the improvement in the measurement, the problem with the confidence intervals, and how, in fact, it has improved in the last 6 years to the degree that, yes, you can draw conclusions about trends towards the MDGs?
Okay, and let's take one more back there.
Troy Jacobs, USAID. I enjoyed these presentations quite a bit, and I have a question about decision makers. When we are thinking about this process of measurement, I really believe that measurement's very important to getting this information back to decision makers. But I feel that when we think about decision makers, we are often thinking at the macro system level about who those decision makers are. And ultimately, the decision makers, and there was a joke about this, that the women that are not going to the facilities are not going for very good reasons. They are rational decision makers, and ultimately, we want to be getting the data and the measurement back to them and to the communities to empower them. Any thoughts about how to do that?
Okay, why don't you guys take a shot at this?
I'll just quickly answer Alfredo's question about midwives working in basic emergency obstetric care facilities or health centers, whatever you want to call them. I think that's a really interesting idea, and I think we have lots of situations in Africa, especially in Ghana, where I'm very familiar with, where the time is ripe to do that. And in fact, that was very strongly recommended recently in a health sector review there. The reason we didn't show quality of care and the effect of upscaling, if you like, or improving the quality of care in basic facilities is because AMDD published it recently. Certainly, there's lots of experience to show that it is the most difficult level to really get highly functional. And if you look at the 6 emergency obstetric care functions that basic facilities are supposed to provide, Usually they can provide 3 or 4 at the most. They don't manage to provide things like manual removal of placenta and removal of products of conception. And I think those things tend to be the most difficult to do. I think you're right. There is time and place for a demonstration where we can show that this really will work, and I'd like to be able to advocate for that with you. Yes, it's a good point. Thank you very much for that.
Okay, the 2 other questions, Charlie. How long have we got? My view on measuring maternal mortality has changed over the last 30 years now, since invented the sisterhood method in 1987. And when that was developed with Professor Brass, I thought, within 10 years it would be obsolete. But it continues to be used in its variant form in macro to this day. So it's been a very interesting 30-odd years. My view is that you can measure it, you have to invest. I mean, the real issue is people have assumed you can measure this outcome cheaply. It's the same way as you can reduce maternal mortality cheaply. And the question is, that's unrealistic. You can measure maternal mortality. My view now is that you can use a variety of cross-sectional approaches. I think the 2010 census is an opportunity, but that's only every 10 years. That's not going to address the local need. My view is now is to really push for complete enumeration of births and deaths. Now, that's going to take time, I know, and of course people raise their eyebrows, but if you don't start, you'll never get anywhere. And some countries have gone about this through sentinel surveillance or sample registration, for example, in India. So you start in a phased way, but you don't shoot it out the water. You need continuous local level information for decision-making on births and deaths, not just maternal deaths, other deaths as well. So within Impact, we've contributed to the armoury of tools on measuring maternal mortality. There's a variety of new ones that are fit for different purposes. But behind them, there should be a longer term. There should be the goal should be all deaths. It's a right. It's a right for births to be counted. It's a right for deaths to be registered. And I think there are ways, but you need to have funds to put it in there. The real problem has been there's been so, in lots of ways, you would argue, little resource going into the supportive services, that spending a lot of money on the measurement is, however, I see 30 years on, what you count is what you do. We should be making sure those deaths are there. And when I've seen the power of those numbers at a local level, there's nothing tougher than going along and saying, even in your sub-district, you've had 4 deaths. That's the power. So it can be done. You've got to put the resource in there, and you do have to count them all. They all need to be registered. The other question about reaching with women and providing information back to them. I mean, one example of this, some of the qualitative work that followed women for several months in Burkina Faso. They have gone back and had Durbas, or they've had feedback meetings to the community. And I think that's important to do. That's research. So having completed a process, feeding back the results. I think the challenge is, how do you do that continuously? How do you not do it as a one-off? We tell the community once, and then how do you systematize that dialogue with the community in ways that it provides useful information? I don't have the answer. I do think, I put a whole list of potential audiences that was mentioned civil society. I think we can be more specific about members of the civil society that need that information. But I think, I'm looking at some faces in this audience, for example, Doyen at AED. There is a challenge there, and it won't be the same way everywhere. So what we need is some lessons on best practice in reaching those communities. So thanks for your question. And maybe Doyen wants to add to that.
Sure, yeah. Pass the mic up here.
Yes, thanks. I just wanted to comment on Burkina Faso. Mm-hmm. In 2006, AED and USAID supported the country to apply the Reduce Alive advocacy model, which actually presented the magnitude of the problem and kind of the implications for economic development. Not as though we costed lives, but at least tried to project how much the country was losing by virtue of its high maternal mortality rates. And I do know that the country decided that they were going to subsidize cesarean sections to $20 rather than the 70 or 130 that it was, prior to this. Did you find a change following this policy decision?
Okay. Thank you very much, Dwayne. I mean, that policy actually kicked in since we completed our evaluation. We have been back, and the issue now is, for two things. One is the quantitative data that we have. Obviously in the Reduce you use modelled estimates of maternal mortality. What we can show is empirical data at a local level in terms of levels of mortality. So it'll be very interesting to input that to that model and see what happens. In terms of the 80% subsidy, it's 80% of the costs of delivery, emergencies and normal deliveries are subsidised now. That has relatively recently kicked in. It started, I think, in 2006, but it's not really been fully implemented. And we were there very recently. Perhaps Sophie might add to this. And what's interesting in Burkina Faso is they are addressing many of the problems that we saw in the free delivery strategies of both Senegal and Ghana. Burkina Faso is trying to address. Therefore, our question back to them is make sure they demonstrate how that policy, how the policy has been implemented and the sort of effects. It could be quite a model policy, and it would be nice to have the robust evaluation in place for them to show health gain. We need some examples of successes as well as things that perhaps haven't worked as well as we would like.
And I know that they're also using their HIPIC funds to train surgeons and deploy them to areas, where you have the most needy. So this would be something nice to follow up.
One thing I just want to add to that, there are several West African countries right now that have either made C-section free or have a sliding scale. And I think it's a very exciting development and absolutely needs to be monitored carefully to make sure that these C-sections are being done for the right reasons. And so we know absolutely nothing about indications for cesarean section in the developing world. Nothing. And we did, one of the things we didn't talk about, but we did work on this within Impact and have come up with a set of recommendations for what routine reporting and routine health information systems should be on indications for cesarean in the developing world. Because the beautiful thing about this is those data exist everywhere. Any place a cesarean section is being done, those data are written down. Nobody, and we looked around the world, nobody is compiling them and looking at them. It can be done. And so particularly if C-section all of a sudden is more accessible, you want to make sure that you're getting those absolute maternal indications covered before you start moving into other possibly.
Well, I'll just add a final point on the Burkina. I think we were quite impressed by the thoughtfulness of their implementation strategies. And this comes back to a very practical issue, which is it's all very well introducing policies, but often policies are implemented very badly. And that in terms of not thinking through the systems, not collecting the information, not providing adequate funding, very, very kind of practical issues like that are often not done well. And it's early days in Burkina, but our impression there is that they have gone through a long process of development of this policy, and it's looking very promising. And so, as Wendy says, we're trying to support them to really monitor and evaluate it well, so that we can hopefully be talking about the gains that it's achieved.
Okay, I know there are several more questions, but I'm afraid we have to leave it there. We're a few minutes after the hour already. But thank you very much to our presenters. A couple quick announcements as everyone's packing up here. The first is that we have lots of materials over there on the table about Impact. If some of them start to run out, please leave your card and we'll be happy to get in touch with you. Also, as I mentioned, the PowerPoints will